Good evening, everybody. We'll be getting started in just a few minutes here. We had a lot of people register, and looks like we have a couple of late stragglers, so give us just a couple more minutes, and we'll get started. Thank you. Okay, good evening, everyone. Tonight we have Dr. David Smith with us. He is an MIT-trained engineer who did his medical training at the University of Chicago. He has been a practicing physician for over 30 years. Dr. Smith is an orthopedic surgeon with Bone and Joint Physicians, and they have multiple locations with offices in Oak Lawn, Orland Park, Flossmoor, and Calumet City. As we go through the presentation, if you think of any questions, please type them into the webinar panel, and we'll go through them once the presentation is complete.
Hi, everyone. My name is David Smith, and as Jim said, I'm an orthopedic surgeon with Bone and Joints. I usually start off with this first little titled saying total knee replacement is not the total answer, because I see a lot of patients in the office and they've been told they have arthritis and that what they need is a knee replacement. So I like to let people know there's other choices. Total knees can be excellent for some patients, but they're not required for everybody. So let's just learn a little bit more about the knee and some of the things options you might have. So there's our group, and we've got 4 offices. So we're pretty much covering the south side. Today we're going to talk about knee pain causes and treatment options. The common problems I hear people coming in complaining about are pain, instability, which means a knee that's too loose, it just you can't depend on it, it feels like it's going to give out on you, and stiffness. So how do these problems come about? This is something years ago, when I first went into practice over 30 years ago, I read in the paper that they asked patients problems that what they didn't like about doctors, and it was kind of a long list, but the biggest complaint was we didn't communicate very well with people. So they sort of formulated what were the things that patients wanted to know when they saw a doctor, and these were the 3 principal questions, and they make sense when you think about them. First, people want to know what's wrong. They want a diagnosis, and they want it in terms that they can understand. I don't want my car mechanic to tell me some complicated thing. I want him to just tell me there's a hole. If there's a hole in the oil pan, just tell me that. Then they want to know what they can do about it, what the options are. And the third is, how's it going to turn out? Is this something that works every time or works half the time? So I use the example of Sherlock Holmes. Actually, the author who wrote Conan Doyle, who was the author of Sherlock Holmes, modeled the great detective after a physician in Scotland who was very good at examining patients, looking for little clues and determining their diagnosis in days when we didn't have fancy tests like ultrasounds and MRIs and x-rays. So every good detective has to gather information. And the principal means we use are history, patient history, physical exam, x-rays, ultrasound, and MRI. Patient history is still very important. They used to tell us in medical school if we would listen, 90% of the time the patient would give us the diagnosis. So I find that very important. The only thing I'd recommend to patients is sometimes I just want you to explain to me in simple terms what makes it worse, what makes it better. Oftentimes I find there's a tendency to come up with a diagnosis, and then it's hard to get past that to get the information we need to know. So I'd rather someone come in and tell me that their knee bothers them when they go up and down the stairs, or when they kneel down trying to lay a new floor, or when they go for a walk. Those sorts of simple things, whether it feels like it's going to give out because it's stuck or because it feels too loose. Physical exam, laying on of hands is still very important. We can get all these tests, but what we know is a lot of times tests have what we call false negatives. In other words, it shows something that seems to be the problem or could potentially be the problem, but when you try and confirm it on the x-ray, you confirm it on physical examination, that's not the area that's really the cause of the problem. X-rays. I threw this in. Everyone pretty much knows if you complain about your knee, you're going to get an x-ray, but sometimes patients come in and they'll bring x-rays with them, and then they wonder why I want to get another film. And the reason is we want to see a weight-bearing film. That gives us an idea about the gap between the bones. When you look at the x-rays here on the left, you can see this little narrow on this medial, on the big toe side, kind of normal on this side. If you take that x-ray with the person lying down, a lot of times they'll look fairly equal. We're looking for these patterns in particular when someone has complete loss of joint space. And that may not show up if the films are not done weight-bearing. Ultrasound. You think of that more in terms of pregnant ladies and looking at babies, but some of my patients can't have an MRI. They have either a pacemaker or some device implanted in their body. It doesn't allow them to have an MRI. And we use the ultrasound quite a bit to look at the tissue. This little one here, you can kind of see these white lines. That's the bone density being reflected. This little triangular section here is a structure known as the meniscus, and what we see is a cyst, this dark area here. And then the ultimate test, if you listen to any sport, pretty soon you're going to hear about some guy being injured and how they're going to get an MRI the next day. And if we look at the films here, this is a knee looking at it from the side. Here in the front is the patella or kneecap. We see the tendon here in dark black below it. We see the kind of gray cartilage that just behind the bone. We see it. This is the thigh bone or femur, sort of shaped like a car wheel. And this is actually, I'd call that the tread. That's the articular cartilage. And there's another structure you hear a lot about, the meniscus, and it shows up as these black triangles. And if there's a tear, oftentimes we'll see a white line going through there. And the meniscus is very important to functioning of the knee. So we see tears that occur from injuries in younger people. And people my age, we see tears that occur just from wear and tear of everyday life, and they'll show up as an abnormal white signal. So that's an important test. Here's the calf muscles in the back of the leg. So you can see much more on an MRI than you can see on an x-ray. So all those things together give us the information to do the detective work that a doctor needs to do. So how to get an understanding of the sort of things that can go wrong in a knee. Here's a book about John Hunter. I was in London several years ago, and I went to the Hunterian Museum where the specimens that this man had collected in the 1700s were all there. He was, you might say, obsessed with human anatomy, and he became a great surgeon because he understood human anatomy so much better than the other physicians of his time. And we can still learn a lot from anatomy. So here's just a quick and dirty look at the knee. First we see the two bones, the femur and the tibia. When you walk, take a step, body weight goes from the femur down to the tibia. To make that tolerable, that the pressure is distributed evenly, we need healthy cartilage. That's this white, smooth, glistening tissue here. And on the tibial side, on the top of it, there's also a layer of cartilage. And when that wears away, that's when we look at the x-rays and we see that space is narrowed, sort of like the tread on your tires wearing out. Then there's another structure called the meniscus. And it's like a little C-shaped pad that sits there and helps cushion, sort of like carpeting, covers your good hardwood floors. This covers the cartilage and helps protect it. That can tear. And when it tears, it can cause pain. and can cause further damage to the cartilage. Then there's ligaments, almost like ropes that connect the bones together. There's four major ones: the lateral, collateral, medial collateral. These are the ones on the side. Then there's the two crossed ones called cruciate ligaments. You hear a lot about the ACL. It's commonly torn in contact sports. So any of those structures can malfunction, be injured, and cause problems. Some from injury, some just from age and wear and tear of everyday life and work experience. So if we're going to play the part of the detective, then we need our list of suspects. So when I'm in the office and I'm seeing patients before I go in the room, I usually have some information, and I'm looking at their age and I'm looking at the story of what led them to come in, and I think of these structures. Could they have a tear of their meniscus? Could they have a tear of a ligament? Maybe not a new tear, but something that's been there for a long time, and the resulting loss of function of that ligament has resulted in other problems such as arthritis, loose bodies, or inflammation in the joint called synovitis. So these are some of the main suspects. What is arthritis? Well, you'll hear different expressions: wear and tear, degenerative joint disease, osteoarthritis. What are the elements that cause problems inside an arthritic joint? One is inflammation. The other is mechanical problems caused by the loss of that coating cartilage. So I always like to discuss this a little more fully. The more you understand what generates the pain, I think the easier it is to understand the different types of treatment options. So inflammation is redness. When I arthroscope or scope or look in a knee at surgery, oftentimes, if it's abnormal and inflamed, it'll look very red, almost like someone's just fell asleep with their hard contacts in, or someone got something in their eye. You'll see the blood vessels distended. You'll see the redness or the weepiness of the tissue. Then there's mechanical problems. Mechanical problem, if you had a pebble in your shoe, that's strictly a mechanical problem. And sometimes the mechanical problem is the overwhelming part of the knee pain. Sometimes it's the inflammation. If 80% of your pain comes from inflammation, and you get a strong anti-inflammatory like a shot of cortisone, that should eliminate 80% of the pain. However, if you have a torn meniscus, if you have bone-on-bone arthritis, then that mechanical problem may be 80% of the problem. And then only mechanical solutions, braces, or even surgery may be what's required. Here's a model of a human cadaver knee. It shows the kneecap here in the front to get you oriented. These are the ligaments off the side. This is called the capsule. Wherever a muscle connects to bone, this is the patellar tendon. These are the ligaments along the side. The reason I like to show this, you can see the capsule is sort of a loose, pliable material, often compared to a light t-shirt. When a person gets chronically inflamed, you can go, if you look at this sort of diagram we have here, the green is meant to indicate a normal, healthy capsule. Sort of a thin, pliable, flexible structure. What happens with osteoarthritis, shown here off to the right, the wall becomes thickened, and it goes from being a t-shirt to a leather jacket soaked in salt water and put out in the sun, becomes stiff. And even the lining of the joint, what's called synovium, that has an important purpose and function to secrete the fluid that lubricates the joint, that overgrows and starts to produce a problem and causes further wear of the cartilage. So arthritis is not just loss of cartilage, even though oftentimes, I know I use the example of a tire wearing out. This loss of cartilage leads to changes in the capsule, the synovium, the lining there, and then with time it can lead to sclerosis or hardening of this bone, which results in more impact stresses on the cartilage. So it's a process that's sort of circular. Once it starts, it keeps progressing. Now, this is something I know patients often say they've been told they have a bone spur. We use the term osteophyte. And I think patients sometimes have the idea that if we just took the bone spur away, everything would be okay. But you can see from this diagram, if you took that spur away, you'd still have a thick capsule. you would have overgrowth of the synovium, you would have loss of cartilage, high pressures in the bone. So the bone spur is seldom the sole cause of the pain. That gives you sort of a diagrammatic view of normal tissue progression to advanced changes of arthritis. So where's the pain come from? Well, articular cartilage doesn't have any pain fibers. You could stick a needle in it and it wouldn't hurt. Synovium, the lining of the joint that produces the fluid, has what we call baroreceptors. It's a little more sensitive to pressure changes. That's why some people say they can predict the weather. Ligaments, those ropes that connect together, they're good at sensing what's called proprioception. What's that mean? That's sort of knowing where your feet are at without looking at them. That's why great athletes have great proprioception. Michael Jordan could jump up in the air and hand the ball from one hand to the other and then dunk the ball and do tremendous athletic feats. And that's that proprioception that comes from those ligaments. And we'll come back to that when we talk about joint replacements as to how many ligaments you left, I think, helps have a better functioning knee if you can leave more of the ligaments intact. Then there's the bone. We're finding increasingly that the bone plays a role in producing the pain because the pressure gets too high. We know that now from looking at MRIs, and I'll show you some pictures of that, but basically it's a thing called bone marrow edema or a bone marrow lesion, and you'll see a bright spot where that bone is being overloaded and the pressures are too high. We've known that the bone is an important part. If you inject lidocaine, which is a numbing agent, into a knee with arthritis, it only relieves about 60% of the pain. So a portion of that remaining pain comes from the bone itself, which is not affected by the Novocaine or lidocaine. So one of the things that's been done, this is sort of an example of how to treat some of these mechanical problems, is to inject this calcium phosphate. We treat it almost as a fracture. We've overloaded this what's called trabecular bone, this fine little bone spicules, and they fracture and break and cause pain. If we reinforce that with this gel, one of my partners is doing one of these tomorrow on a patient who's got this problem. So basically, what is osteoarthritis? Degenerative joint disease. It is a combination of things. It's loss of cartilage, it's thickening of the capsule, overgrowth of the lining, bone spurs or osteophytes. These are the things that affect you in everyday life, causes pain, stiffness, sometimes looseness. So it's not always a one-to-one correlation between what you see on an x-ray. You can have no arthritis and your knees can still hurt from arthritic problems. Sometimes in the early stages of arthritis, x-rays look pretty normal, but the joint is becoming inflamed. Some people will get x-rays of one area of the body and will pick up a joint that's looks arthritic, and you ask the person, how about your left knee? Does that bother you? And they'll say, no, I have no pain. So having changes of arthritis doesn't mean necessarily that joint's going to become painful instantaneously. You can have pain and arthritis in a certain joint, but that could not be, it's possible that won't be the principal cause of the problem. I see people with fairly mild arthritic changes where, let's say, they have arthritic pain coming from their hip. So it's possible that you can get non-arthritic pain that overlies that area. And then finally, the most common thing I see is people with arthritis and arthritic pain. And we've talked about how that can be inflammation and can be mechanical. So we said we were going to try and answer the question, what's wrong? So you could have a torn meniscus, a torn ligament. You could have loss of cartilage. You could have inflammation in the joint. What do you do about it? That's the second question. What are your options? And Shakespeare always had some wisdom. There are more things in heaven and earth than dreamt in your philosophy. And probably that could go true for some of us doctors where we need to consider all the options. My grandmother was a little more plain speaking, and she'd say there's more than one way to skin a cat, and I try and keep that in mind. In fact, some years ago, I thought about how to try and remember all these options when I'm talking, once I've made a diagnosis and I want a person to know what options are available. Because orthopedics is different than a lot of areas in medicine, where we're not dealing with heart disease or cancer. We're dealing with an area where basically the patient knows more about how it feels. That, a lot of times you go to the doctor. Years ago, you used to go to the doctor to see what your blood pressure was, how you were doing. But with arthritis, you know before you go how you're doing. In fact, you're the one who's going to tell the doctor how successful or unsuccessful the treatments that he's supplied were. So what are the 5 categories of treatment that we do in orthopedics on a day-to-day basis? I like to lump them into physical therapy, medications, injections, bracing, and surgery. Let's go through each one briefly to give you an idea. And I think if you keep those in mind, it helps you sometimes when you're discussing with your doctor. Let's say if you do have arthritis and you're trying to determine which treatment approach you want to take. I think physical therapy is one of the mainstays. Today I had office hours, and every time I have office hours, I see patients with knee problems, and the person can't straighten their knee out completely. And that's not a good situation mechanically. Even if your knee doesn't bother, and if you want to just mimic that, try walking around a little bit with your knees flexed, and you'll see after a short period of time, you'll be tired, and it starts to hurt, and you'll want to stand up straight. So if you've got a joint that's already got some problems, and you've got what we call a flexion contracture, you can't straighten your knee out of flexion, physical therapy is an important thing. We have a program we use named after a man named Shelburne, well-known knee surgeon. And we go by the principle of stiff knee is a painful knee, so we have to work that out. The knee arthritis school program we run is to teach patients self-management techniques, and that's very important. Even if I know a person is going to a knee replacement, I want them to go for a few sessions to learn some stretching exercises. The more they can stretch that capsule out that we showed before, get rid of some of that stiffness, they're going to do better after the surgery than someone who didn't do the treatment. So that's an option. You can talk to your physician. You need a prescription to see your therapist, but basically the Shelburne program, which is what we follow in our therapy centers, is first we try to establish extension to get that leg straight again. And once we've got that done, we start working on flexion. To go up and down stairs, to get in and out of a chair easily, you need about 115 degrees of flexion. So that's a minimum goal we're going to go for. So past 90 degrees to 115. And then the final thing we want to add is strength. And there's 2 types of strength. There's the strength to do one lift type activity once. Then there's endurance, and both are important for activities of everyday life. And oftentimes the therapist has other things they'll observe and can help us with as orthopedic surgeons in terms of deciding when a patient needs some postural and gait training improvement. Sometimes you can adapt your style of walking to fit the limitations you have and diminish some of the pain. And therapists are excellent in determining what types of orthotics or braces, starting at the feet. Often I see patients with what we call knock-kneed or valgus knees, and they also have foot and ankle problems that can be balanced out with orthotics. And then we get into all sorts of different braces. We have a little room here in the office that we show patients the different types of brace options available to them. So that's therapy. Then we get to medications. Now, the most common medication that people use in arthritis is what are called NSAIDs. Stands for non-steroidal anti-inflammatory drug. What does that mean in English? It means an anti-inflammatory that's not cortisone. And there's lots of different ones. Motrin, Advil, Aleve, things you get at the grocery store. Not a bad place to start. There is about 100 or more different prescription ones. If you see 10 different doctors, you'll probably get 10 different favorite pills, but they're all fairly similar. They all carry the same risk, and that is they can affect your stomach, your intestines, they can affect your kidneys. Once we get past 60, our kidney function starts to drop off a little bit. It's certainly, we can manage with it, but anti-inflammatories can diminish it even further. So if you're diabetic, if you have a history of kidney problems, you certainly want to check with your internist before you take many of these. I get a lot of questions about chondroitin sulfate, glucosamine, non-prescription medication. There's a lot of misunderstanding as to how it works. It does seem to have a mild anti-inflammatory effect. It doesn't regrow cartilage. Anyway, that's chondroitin sulfate, glucosamine, non-prescription. Nothing wrong with trying it. Capsules are kind of big. Take it with applesauce. It helps you swallow it. And some new things are coming along. There's a couple of them out now. Diclofenac is sold as Voltaren gel. There's another brand that's out. But you rub these over the area, and in the knee, sometimes you may have little areas where it's close enough to the skin that you can get some of this to go across the skin layer. It'll go across the skin layer and get into the tissue and helps with inflammation. What I like about it is you don't get all the systemic side effects. You're not taking it into your stomach and having it go into your bloodstream everywhere. It's just being applied locally. There is some systemic absorption. It does get into the blood, but yeah, I find it's a promising new approach. So there's glucosamine DS, which is chondroitin sulfate, glucosamine. You'll see the name down here, kind of a mouthful. Non-prescription item. So we've done physical therapy, medications, injections. There's three principal types: cortisone, viscosupplementation, platelet-rich plasma. Cortisone, a lot of misunderstanding. In fact, I think we're going to do one of our little webinars. I'm going to do some question and answer periods in the future, and we're always welcome them during all these webinars. And type them in if you have questions. Other patients, I talked about the possibility of a cortisone injection, strong anti-inflammatory. I think, to me, it's safer than the pills because you're not getting that systemic absorption. You're just putting the cortisone where you want the anti-inflammatory effect to work, and it is the most powerful anti-inflammatory. People think if they get a shot once, then they're going to require it in the future. That's not true. They think it's going to dissolve their knee. That's not true. Cortisone exists in your body. It is like anything else. Offer you a glass of water, you're not going to drown. Drop you in the middle of Lake Michigan, you might. So cortisone is the same thing. If we use it in a reasonable fashion in an older person with arthritis, I think it's a very safe treatment. Obviously, if I see a 20-year-old who wants to play basketball on Friday night, I'm not going to recommend that until we know what's causing the pain in his knee. Viscosupplementation, big word, what's that mean? Is to supplement the lubricating fluid that the lining of the joint, the synovium, produces. And this comes in a variety of packages. You hear Suparts, Synvis. It's a chemical called hyaluronic acid. It was found to be low in the fluid of people with arthritis. I've been doing this for about 15 years. I've used all the different brands. Probably the one I use the most now is Orthovisc. Again, every doctor has his favorite. It's one injection a week for 3 weeks. And there are some formulations that's one injection. But I've had better results when I've given more than the one, and I think 3 is a reasonable compromise and works well in the tests that have been done. Doesn't work for everybody. It improves the lubrication effect. It doesn't blow the joint up. When we show those x-rays, people think it kind of blows up or fills the gap when you have bone on bone. That's not true. It basically is a lubricant. And then you get into some of the fancier things. Everyone's heard about stem cells. They've heard about PRP. What is it? PRP stands for platelet-rich plasma. In your blood, if you look over here at the little test tube, there's white blood cells and red blood cells. White blood cells fight infection. Red blood cells carry oxygen. Platelets are involved in wound healing. When you cut yourself, platelets help form the clot. They release little packages of chemicals that are inside the platelet. And this cascade of growth factors and bioactive proteins is thought to help with healing. And someone theorized that perhaps it would help in arthritis, and the jury's still out. Medicare won't pay for it. Insurance won't pay for it. It costs about $500. The safety factor, I think, is very good. Basically, it's your own blood. It's taken out about 100 cc's. It's spun down in a centrifuge. We separate out the platelet-rich plasma and inject it into the joint. I've had variable responses. I had a fellow not too long ago, and he was just so pleased with it. And I've had other people where I've injected them, and it just didn't help them. But it's an item you have to pay for yourself, and it runs about $500 for one treatment. kind of look at it as sort of the caffeine for the knee. Then we get into bracing, and there's a variety of braces, the simple elastic things you get at the grocery store, to the more complicated braces that orthopedic surgeon might prescribe for you. This shows this little red brace down here is a non-loading brace used in some patients who have arthritis on just one side of the knee, and that's a pretty common pattern. Osteoarthritis tends to be a segmental disease. It'll occur in one portion of the knee and not the other. And these unloading braces are very helpful. I've had a lot of fellows in their 50s that are in the trades. They're carpenters, electricians, standing, climbing ladders. Really don't want to get into surgery. And for some of them, the bracing will help. And certainly women can use it, men can use it. Having a little bit of a longer leg with better contours, you can get a better fit. So it doesn't work for everybody. They can be covered by some insurance policies, not all, and they can be very expensive. I always guess the price of $1,200, $1,500. Then there's a lot of braces that are available that are less than that, and we have a lot of the elastic ones we use, and I found they're very helpful for people who have arthritis, because what happens when the joint space wears down, there's a little looseness in the ligaments, and protecting that with a brace can be helpful. But you can start with the simple ones you get at the drugstore, and then talk to your doctor about the more protective ones. And I shouldn't exclude orthotics or braces on the foot and ankle. They can be very helpful. That's where the therapist helps us a little bit, because they work with you on walking and really observe your foot and ankle position, and they can help get you a proper insert for your shoes. Surgery, what's available? Thing called arthroscopy. Arthro meaning joint, scope meaning look. And what do we do when we scope a knee? Well, a lot of times it's for a torn meniscus. Sometimes we see overgrowth of the synovium, so we remove that. Everything with ectomy on it means we're cutting something out or removing something. Debridement, just cleaning out the wear particles. Microfracture, we actually drill holes in the bone to allow the, quote, stem cells, which are in the bone marrow, to come out, and they can partially resurface a joint. ACI went to Europe, and it was in Sweden in 1997, 98 to learn how to do this. It doesn't work in arthritis. It's for post-traumatic areas, usually younger people less than 50 that have sort of a pothole from trauma where the rest of the cartilage looks good. We can take cells out, send it to a lab in Boston, regrow it, and put it back in. Mosaic plasty, sort of like the hair transplant for us men, where you take hair cells from the back and move them around, plugs of hair cells. We take plugs of bone. Subchondroplasty, the thing I showed you with the calcium phosphate, which is a bone grafting material for areas where the abnormal signal, where we see on an MRI, we see those bright signals where it looks like you've had like a had a little fracture in that area. Corrective osteotomy, which basically, probably simple but not very appealing way to say it, is to sort of break the leg, change the alignment to get the force redistributed on the joint, and then joint replacement. So one thing I've used as an example, you drive down the street and you see that rubber tread that's come off tires. When a joint starts to wear the cartilage off, those pieces come loose in the joint, and through the scope we can clean that out, and that does help some people. We can remove the excess synovium, trim up the meniscus, and there are a lot of studies that have shown the effectiveness of it. Here's one that was done, a 10-year follow-up. 77 patients out of 91 were contacted. 2/3 of them, after 10 years, did not have a knee replacement yet. They all had arthritis. About 60% of them, about 6 out of 10, didn't need any additional surgery after 10 years. And only 1/3 after 10 years went on to knee replacement, starting at 7 years out. Good or excellent results for 2 to 4 years. Again, 2/3 to 3/4. So reasonable odds. This just kind of diagrammatically shows we're looking in through the one lens with bright light shining, and then we're cleaning up inside the joint. Some of the devices we use, the instruments we put in there. And these are some of the joint mice or loose fragments that we're talking about. We're talking about rubber tread coming off tires. Well, this is what we get out of these joints. And that gets embedded in the joint. Where does that come from? Well, here's a donor site. This is those craters. And even smoothing off the edges of these can reduce some of the pain in the joint. So arthroscopy can be helpful. It doesn't cure it. There is no cure for arthritis. We have treatments. And you can see what normal healthy cartilage looks like, beautiful white smooth tissue compared to this. Microfracture, we drill those holes. It's been used successfully in some patients if the area is rather limited, worth considering. This is the technique I went to Sweden for, ACI, autologous chondrocyte implantation, where we take the cells and we come back from the lab in Boston, we put them in, we sew these patches over them. Mosaic plasty, taking plugs of bone from areas of less stress and putting it into areas of higher stress. Partial knee replacement, what's that mean? You hear a lot about minimally invasive. Truly, the only truly minimally invasive knee surgery for joint replacement is the partial knee replacement. When you look at a human knee, there's three, you might say three rooms. There's the medial or big toe side of your knee, where it's the most common to get the most serious wear. Lateral, which is the little toe side of your knee, where the femur meets the tibia or thigh bone meets the shin bone. Then there's underneath the kneecap. So those are the three compartments. Most common we show here in this medial wear pattern, and you look at it, this is called the all-back classification, and you see the type 2 and 3 are the ones that are compatible criteria for having a partial knee replacement. When you get to the all-back 4, the only thing you can really do is a total knee. So intervening at the proper time, is like everything else in life, there's a certain art to it. The rehabilitation after partial knee is not quite as easy as arthroscopy, but it's getting closer. It addresses the ligament imbalance. It fills that gap. It addresses the sclerotic hardened bone that forms when we implant these devices. Basically, it's a segmental treatment for a segmental disease. We just leave the normal cartilage and replace the worn out areas. And it preserves bone for the future. A lot of younger patients need a portion of the knee replaced, and if we do that, we know that there's a good chance that sometime in their life it's going to have to be revised. When you look at this little Venn diagram of the different three compartments and how they overlap, you can see here 166 of this total group of patients here had only medial compartment arthritis. 21 had only lateral. 130 had only kneecap. So we can treat those segments separately. Even the overlap of the medial and the patellar can still get good results with a partial knee replacement. What's it look like? It's a metal runner on a plastic surface with a metal platform underneath it. And these can produce very good results. We look at some of the survival rates for them, and you can see 15 years, 86%, some at 90%, so a good success rate. Comparable, in some cases superior to knee replacement. Here was one study that showed it actually lasted longer, which is a little surprising. You wouldn't expect it to, but it did. So this is a 15-year follow-up on uni or partial knee replacement. And the important thing here too is look at the excellent. You know, these outcomes are often rated as excellent, good, poor, fair. So 71% were happy with the unis. This is something I see all the time, that a well-placed uni will beat the total most times. And they had, at 15 years, 90% of them were still going, while the totals were 76%. Something to keep in mind. Total joint replacement. This is something I'm going to do a future webinar on, or maybe one of our podcasts. Just talk about the different types of implants. But basically, there's 4 major ligaments. I prefer, when possible, to do the CR knee, which leaves 3 of the 4. Some doctors like to go immediately to what's called a PS, and only have two of the ligaments. Both cruciates are taken. And then in some cases, if those ligaments, those remaining two ligaments, are not that healthy, they go to what's called a constrained or stabilized. And there's issues with each one of these. So it's important, if you're in that category where you're thinking about knee replacement, to start to appreciate some of the differences, advantages, disadvantages. You know, for 30-some years I've been doing these implants and going to meetings where it's discussed. So no one has all the answers, but I think logically, if you can maintain more of the normal tissue, the better you are. Too early, too late. So as we showed on that all-back classification, as time progresses, the arthritis progresses. You may go past the point where you could have had a uni, and it advances on to where a total is required. And I usually like to start with the CR over the PS, and constrained is really when things have really gotten out of hand. So, surgery. You hear a lot of different things, but this is something I've used for well over 10 years. It's computer-assisted navigation. It's sort of like the GPS for your car. Allows us to implant these devices in the optimal alignment. I've been pleased with it. There's some other approaches used. They have these what are called patient-specific molds. I've used those. They certainly are good, but I think this gives you a little more flexibility. We use these light-emitting diodes in surgery, and we can move the knee and see and set the cuts and spacing. This is the one we have at Ingalls. You can see here the patient's on the table, and then this sort of robotic eye is shining down and telling us, you know, where the position is. We can watch on the screen and really fine-tune the alignment. So if you do decide to have a total knee, what's important is go someplace where they do a lot of them. They have an interest in it. It's like anything else in life. The more you do, I think you should get better at it. Ingalls is a high-volume joint center. We do a lot there, and so I think that's a good choice. They have nice rooms, excellent nursing. You know, that's really, I mean, it's important that, you know, you want to get a doctor who knows how to put them in, but you're going to spend a lot of time with the nursing staff, and that's important. And Ingalls has an excellent one. Important thing is, in all these things, once you understand what your problem is, what your choices are, what's the outcomes. In other words, is we're looking at some of those outcomes there, 15 years, 2 out of 3, 3 out of 4. But know where you want to go. What are you interested in? If you enjoy reading and you can get along with just some injections and maybe a brace, that may be optimal for you. You maybe watch the grandkids play baseball and you'll be happy. Other people, I've had people that put total knees in their 80s who water skied. So we've got to set our own. That's something you want to talk about with your doctor. What your goals are. Do you want to play golf? You want to play tennis? What's realistic? Certainly the what's allowable with these implants is much more than it ever has been, and I think the materials have improved quite a bit. So this is the part where any questions come in, we'd be glad to answer them. Just type them in and we'll try and cover them.
Okay. First question comes from Claire. What can be done about loose cartilage, clicking sound when bending the knee?
Well, one of the things for the loose cartilage, first I want to just say something before we answer any questions. I think it's really important for people to understand you want to have a relationship with your doctor. You don't, no matter what you hear on the internet, including me, we can't really diagnose your case over the computer. So I want to give some general information, general thoughts, but listen to your own orthopedic surgeon. In any case, what can you do for the loose bodies? Sort of like we showed there, arthroscopy comes to mind. We can wash those out. It does help a lot of people. Getting rid of joint sounds, I'm less optimistic about the ability to do that in a consistent fashion. The problem is, once you get arthritis, it's not a smooth surface, and it's more likely to make sounds. Even the total joints can make some sounds, and that's disconcerting to some people. But unless it's associated with pain, I think most people can get used to it. I know when I go up the stairs, it's a little noisier than it used to be, and I don't think it's the stairs. It's just your joints get a little uneven wear. But you can wash those particles out. I think that does help. So to answer your question, Claire, I'd say arthroscopy would be certainly a consideration. The other thing you could consider are the gel injections. That's a lubricant. It helps, and you may want to try that first.
Okay. The next question is from Christine. Does Dr. Smith do knee replacement procedure called spare the quad?
Spare the quad. Well, we try to spare everything we can. I've done the quad sparing surgery that where we would do an approach called subvastus, midvastus. Subsequent research has shown some problems with that. And one of the problems was we were denervating, we were stretching one of the muscles, and it did cause some of those muscle fibers to not work as well. So there's nothing without some advantage and nothing without some disadvantage. Yes, I do that, but there's very few patients that are really candidates. It can be done in a smaller leg and a smaller knee. And I think it's important for the person to understand that doing that subvastus and midvastus approach can result in some damage to the muscle. And there really hasn't been any solid evidence that long-term it results in any improvement.
Okay, Christine has a follow-up question. When you have a knee MRI, does your body go all the way into the MRI machine, or is it just your lower body?
In the extremity ones we use, it's just your lower body. We have those in the office, and I sympathize with people with claustrophobia. As I've gotten older, I know I've gotten it myself. So, yeah, the extremity ones are nice because you can just put the joint in, and your head, arms, and legs are pretty much free.
Okay, question from Felicia. How long is the recovery period for these procedures, the surgical ones? Just ballpark.
Sure. For a scope, it's done as an outpatient. You go home the same day. People are on a crutch for about 1 day. I tell them to avoid any kind of sporting activity other than physical therapy for about 6 weeks. So that's an arthroscopy. For a total knee, that's somewhat variable. I saw a bunch of patients today I did total knees on. I'm trying to think. I saw ladies that were, a couple of them were about 5-6 weeks out. They were off the walker, reporting pain levels at 1 or 2. So that's one measure of recovery. So let's see if I can make sure I'm answering this completely. So I'd say in the hospital, average would be 2 to 3 days. Using a walker or crutches for 4 weeks. In physical therapy, probably for 3 months. And certainly you'd be better at 6 months than you were at 3 months. Depends a lot where you start. It's sort of like if you ask me how long it takes to get downtown Chicago, I'd say, well, it depends where you're leaving from. If you're out in Oswego, it's going to take longer than if you're here in Homewood Flossmoor. So if you go into surgery and you've got fractures, you've got weakness of your muscles, you haven't rehabbed the knee, then it's going to take you longer to recover than someone has a milder stage of arthritis. But it is, for a total knee, it's several months of therapy, and usually at about 6 to 8 weeks, most patients are beginning to think it was the right thing to do.
Okay, additional follow-up from Felicia. What if your knee doesn't hurt, but you have been told by your doctor that your knee is shot?
Well, there you go. That's what I was talking a little bit about. That's the thing. You can have x-rays that show an abnormality and really not have much pain, and that's good for you. And it's not all that unusual. I mean, I always want to treat patients. I don't want to treat x-rays. So that's what that means, is that you've shown some wear, and the knee probably is susceptible in the future to develop some problems. But as my mother wisely observed, don't borrow trouble. If things aren't bothering you that much, then I wouldn't necessarily worry about it. You might just take it into, I think what your doctor may be saying to you is that, if you do show advanced changes of arthritis, it's probably a good idea not to take up jogging, probably not to, do too vigorous a home repair work. Just keep it in mind that it's something that you could flare it up a little more easily than a healthy knee, but certainly never ever do surgery just for treating an X-ray diagnosis.
Okay, question from Sonia. Would a primary care physician be the person to administer a cortisone shot, or do I need to see a specialist?
Well, I think a lot of primary doctors give cortisone injections and do an excellent job. So I don't think you need to see a specialist for a cortisone injection. I mean, it depends what your doctor is comfortable with, but it's a fairly routine thing, and I'm sure the primary doctors, most cases would be doing that for you.
Okay, Mavis asks, from the time you first feel pain go across the front middle of your knee when walking upstairs, it doesn't hurt any other times. How long is it safe to wait to have it checked out? And does this sound like osteoarthritis?
Yeah, it does. I mean, it certainly sounds like osteoarthritis. I see the stair climbing thing usually is putting a lot of stress on your kneecap. And there's a condition called chondromalacia, which we see more in women than men, and we see it in younger men and women, people in their 30s and 40s, and even as far as teenagers in some cases. So, but if you're in your 50s, 60s, likely you have a bit of arthritis underneath your kneecap. So I wouldn't feel there's any urgency about doing anything about it. It's a fairly common thing. Like, a lot of us men have less hair than we did when we were younger, and the hair is a little grayer. So a lot of changes in life they're not a disease, they're just part of life. So I wouldn't be overly alarmed at that. So I often tell my patients, I look at stairs as something to be an obstacle to get around or get up. You don't get points. If you have to, lead up with one leg and reverse it coming down. So if the knee that's making the noise, step up with the other leg and bring the other leg up to join it. You don't really get style points for stairs. But I wouldn't be overly alarmed about it. If it's bothering you a great deal, then you may want to see a doctor, get an X-ray, and see what your options are.
Okay, Mavis had a follow-up question. Could I do an MRI if I have already had a hip replacement?
Yes, you can.
Perfect. All right, Christine asks, I have been getting anti-inflammatory shots in both knees for about 4 years. I have been told that in time shots will not work anymore and they will harm the bone. Can you clarify or elaborate?
Sure. If you're getting the visco supplementation, I have a lot of patients. Like I said, I've been doing this for about 15 years, and I mean, it's certainly possible your arthritis is going to progress. It can, but one thing I've found that doctors are particularly poor at, and that's predicting the future. So there's a possibility that as time goes on, maybe the injections won't be as effective if your arthritis gets worse, but no one knows that for sure. And I would just enjoy my life, and if the shots are helping me, stick with that. If it gets increasingly worse arthritis, and then you've got other options, including surgery, bracing, therapy, things to consider.
Fantastic. Okay, we had a couple of emailed questions that came in before the presentation. We've talked about them briefly, but if we could recap them. From Michelle, what is the average recovery time after surgery?
Well, again, if it's a scope, you're talking about going home, coming in and out the same day, being on crutches or a walker for 1 day, going to therapy for a few weeks, and staying away from more aggressive sports for about 6 weeks. For people who work in an office, I've done doctors who did them on Tuesday and they were back at work on Thursday. If secretarial, or I guess we call office work, again, a person could do it on a Thursday and be back in the office on Monday. And if you're working the trades and heavier work, then you probably need a few weeks at least. For a total knee, again, it's the same thing. It's basically you're in the hospital 2 or 3 days. You're on a walker for 4 weeks. You're in physical therapy for about 3 months.
Okay. Another set of emailed in questions from King Riches 2. How to keep my aching knees warm during winter months?
Well, I think the first thing comes to mind is thinking about braces. You kill two birds with one stone. I think it gives you a little bit of warmth, and and in the simple brace is not a bad place to start. They have these. I know when I go to the grocery store at the Jewel or Osco, I'll just go through and look at that little section. There's a lot of elastic braces. You can go to, I think it's Sports Authority, and they have different braces, and some relatively inexpensive. That just for warmth, that'd be good. I go hunting a lot in the winter months. I'm outdoors at the farm, and long johns are still pretty good. I was thinking of those fancy things the ballerinas wear when they come out. The ladies probably know more about those, but it's kind of those woolen things you pull over. But I think long stockings are probably a good thing. And I do think it's wise to, if you do have some arthritis, to, when you go outside in the cold, I think you'll feel better if you do keep the legs warm.
Okay. Question number 2. My knee swells when walking or standing for a period of time. Does it mean I have fluid buildup in them?
It's reasonable to assume. I mean, doctor would need to examine your knee, but that'd be a common explanation. The old expression, water on the knee. There are joints where people get up in the morning, they're doing pretty good. As the day goes on, they tend to swell. And that's a sign of inflammation. Sometimes you can handle it with pills, sometimes with shots.
Okay. Last question from King Riches. Sometimes my knee buckles underneath me while walking. What does that mean?
Well, there's two common causes that I see. One is a torn meniscus can get trapped in the joints. Sometimes these tears are just lying flat and they're not causing any problem, but if you turn or twist on them, that piece will stick up and it can jam in the joint. And it's sort of like my parents used to have this card table with folding legs, and if you didn't snap it all the way out, it would collapse. So basically, when you walk, if you don't lock your knee out in full extension, you're a little susceptible for the leg to buckle on you. So a torn meniscus can do that. Also, people with arthritis, as we walk, there's sort of a rhythm as you go, and you swing the leg through and then you extend it. Well, with arthritis, sometimes it'll catch. It just doesn't slide and glide normally. And then if you haven't fully extended the landing gear and you put your foot forward, you get that sense that it's going to give out on you. So arthritis and a torn meniscus could be the bad guy.
Okay. Erlene asks, when your body swells from metal or plastic, what happens if you get a knee replacement surgery? Can the surgery be replaced? Reversed?
Well, you'd really want to explore. I mean, the common metal allergy that I see is that people have what's called a nickel allergy. Some of the less expensive jewelry, I don't know much about jewelry, but has nickel in it. And so then I use an implant that has a special coating called oxinium. But this is something that's still not fully understood. I know at the American Academy of Orthopedic Surgeons meetings, there were several talks on this subject and how you go about making the diagnosis. But I think the precaution I would take is to use this special coating material called oxinium. As to allergies to plastic, I really, the polyethylene, as far as I know, has been handled well by this highly cross-linking technique that's used where it minimizes the wear, and usually I'm not aware in my 30-some years of doing total knees of anyone that I've felt that they had a problem because of a plastic allergy.
Okay, looks like we have just a couple more questions. Lee asks, I sprained my right knee and I was wondering why I'm getting the same pain in my left knee. Is this due to additional stress on my left knee?
I think that's a reasonable explanation. I mean, I see a lot of people that have a similar story. And then, of course, you have to keep in mind, let's say if a person's 60 and your right knee is 60 years old, so's your left knee, and sometimes these things start to go out about the same time. So let's say it was arthritis, it was just acting up. It wouldn't be unusual to get a flare-up in both knees. But your theory of compensation or trying to make up for the other leg is certainly a very realistic possibility.
Okay. Question from Felicia. My knee gives out. Sometimes it will go back like a flamingo, meaning it doesn't lock. just keeps going back, but I catch it before it goes back all the way. Just a twinge of pain until I wiggle it around to align the bones up. I had an MRI. It was not good, but still no pain. I just don't know what to do next.
Yeah, and those are the hard situations, certainly, where, if it's bad all the time, then it's a little more clear. It sounds like you're having some instability. I do think physical therapy, strengthening, you can balance these things out. It's amazing to me how often therapy can help correct problems like you're talking about. Supplementing it with a brace, particularly after having your knee examined by an orthopedic surgeon to see if you have any ligamentous instability. But a lot of muscle imbalances can result in that. If you have some arthritis, sometimes the gel injections can help with the lubrication. So needs to be checked.
Okay, I think that's the last question that's come in. So unless there's any other questions, you're going to get an email at the end of this, offer the chance to give us some feedback. If you think of something after the fact, let us know. We'll be happy to communicate via email and respond to your questions. We do these monthly. The topics vary from month to month. In fact, I think next month we're going to incorporate the shoulder into the talk, and maybe the month after that we might do the hip. We have a website, boneandjointworld.com, in which we have recorded a number of these videos, and we do put them there so you can watch, or you can watch them at your discretion. There's a lot of content. There's podcasts that we're doing, plus our calendar of events, so you can kind of see what's coming up with not only Dr. Smith, but other physicians we have on staff. So we'd like to thank you all for coming, and our number's on the screen. We'll leave it up if you want to give us a call to make an appointment. And again, to rewatch this video, it can be found at boneandjointworld.com. Thank you, everyone. Have a wonderful night.